Mike really needs no introduction. He graduated from our residency last year, but if anybody doesn't know Mike Meyer, then I will tell you he's a major in the United States Army. He graduated with honors from the United States Military Academy in West Point, which is an amazing feat in itself. He graduated with a degree in mechanical engineering. He went off and then served 4 years as a combat engineer. The very proud combat engineers, they have a long history. As a combat engineer, he was mostly based at Fort Hood, but he took a year tour to see the world, and he went to Iraq, where he served with quite renown. I say that because he won the Bronze Star Medal. You can only win that award during wartime, and he won it for, I'm sure, courage and action. And he also won the Steel Order, the De Fleury Medal, named after a French engineer that helped the Americans during the Revolution. It is given, the Steel Order is given to young junior officers that proved themselves to be invaluable to the engineers. So Mike was a true combat engineer in Babil, Iraq, and he came back and finished medical school with honors in 2016. He then got into our residency. I remember him back then, and he did an amazing job. He's won all kinds of awards. He was the valedictorian of his medical school class. He is he is AOA. Okay, they still have that at UShoes, where he graduated medical school, and he's won all kinds of awards uh, um, from airborne on. From an academic viewpoint, he has produced or contributed to over 23 peer-reviewed papers, multiple chapters, and other things. He was a wonderful resident, culminating in winning the Courage to Lead award last year as the sole graduate with that award. And he has gone on to work under the tutelage of our endovascular folks here as a fellow, and he's going to give a talk on an interesting subject and paper. Mike, without further ado, thank you for your service. Thank you for your courage during wartime, and thank you for being a great resident and a great doctor. You've been wonderful. Thank you. All right, go ahead, Mike.
Thank you, sir. I really appreciate that. I'm gonna share my presentation here. So today I actually gave the talk on this before, preliminary data, but this is the final data from our project we've been doing for a little over 3 years here at Harborview, prospectively comparing CT angiogram, which we've been doing routinely on all patients with penetrating brain injury since before I started here, to digital subtraction or catheter angiogram to compare them for the diagnosis of penetrating cerebrovascular injury. I'll get into the prior studies, but there had never been a prospective study comparing that. And our goal was to try and publish the first one and ideally change the actual guideline recommendation on whether or not angiogram was recommended. We submitted this to the Journal of Neurosurgery, and actually on Monday of this week, it was accepted. I don't have any disclosures. So the background studies for this topic, first of all, cerebrovascular injuries are common, or at least we think they're common after penetrating brain injury. They're the largest series ever published on the topic, found a 30% incidence of any type of cerebrovascular injury, which in that particular study, what they included were pseudoaneurysms, dissections. They didn't in that study say what size and location of vessel qualified, because there's obviously a difference between an extreme distal M4 branch and the supraclinoid ICA. But dissections, dural fistulas, and then occlusion of any large vessel or dural venous sinus. And then other studies have reported ranges all the way from 5 up to 40%. All the studies of any significant size are actually all published in wartime population, which is a general theme about penetrating brain injury research. The majority of outcome studies, the only studies on vasospasm related to penetrating or blast injury have all been published in soldiers and civilians injured in war. The previously published civilian cohorts were all retrospective that included all mechanisms. And those said that the sensitivity of CTA compared to catheter angiogram was about 70%. One published 70 and the other was 72. However, and they actually, one of these papers specifically discusses this in their manuscript. These were retrospective cohorts, and by design, that means that not every patient that was seen at the centers that participated in enrolling patients were routinely getting angiograms on everyone. And the whole question is whether or not CTAs miss a significant number of these injuries. And by having it a retrospective design, it's unavoidable that there is some selection bias. There is likely a reason that certain patients proceeded to getting an angio and others didn't. And it could have been that the CTA was concerning or inadequate because of artifact or something like that. Or it could have varied between, who was on call. And because of that, almost certainly that 70% sensitivity for CTA compared to angiogram is high. And they actually, the larger of those two series recommended getting an angio anyway. There is a single prospective study that was done in a civilian population comparing CT angiogram to digital subtraction angiogram that has been published, but it was limited to stab injuries only. It was published in South Africa, and when I was starting this project, I actually talked to Chris Young, my former co-resident, graduated a year before me, and he's from there. In South Africa, apparently knife wounds and machete wounds to the brain are common, which is probably why they published that. But in every series I've read on penetrating brain injury in the United States, and of course during war, they're not. They make up a very small minority of the mechanisms that we see. So while that study was prospective and interesting, it's kind of limited in its usefulness. And then finally, there's actually everyone knows the Brain Trauma Foundation guidelines for the management of closed head injury. We can talk about them a lot. Dr. Chestnut's contributed pretty heavily to them. But there are actually guidelines for the management of penetrating brain injury too, which even me, and I'm pretty interested in this topic, didn't know about until the last few years. But they've been around since 2001. And they do have a specific section on management of penetrating vascular injuries, and they recommend either a digital subtraction angio or a CT angio for patients with suspected cerebrovascular injury after penetrating brain injury, but they don't recommend one or the other. And that wording is what it actually says, suspected of cerebrovascular injury, which is important because that's different than saying it's recommended for everyone. And the person who was in charge of the process of writing the new set of guidelines, which should be coming out in the next year, is actually a mentor of mine from medical school. And he and some others involved in that project felt strongly that the recommendation needed to be everyone with a penetrating mechanism brain injury needed to get some form of vascular study, and he specifically, his name is Randy Bell, he's on the author list I showed earlier. He thought that an angiogram was probably necessary, but there wasn't a study good enough to prove it. And that was our goal. So moving on to our study, we wanted to prospectively determine the incidence of cerebrovascular injuries in civilians who have penetrating head injuries. Those incidences I talked about before were all during war and or retrospective. And then to calculate the sensitivity and specificity of a CT angiogram for cerebrovascular injuries with the catheter or digital subtraction angiogram used as the gold standard for those calculations. So this is a multi-center prospective cohort that enrolled consecutive patients presenting with a penetrating brain injury of any mechanism for a 3-year period, May 2020 to May 2023, here at Harborview. And then we had one other participating center, the University of Utah Hospital in Salt Lake City. Ramesh Grandi is their vascular and trauma neurosurgeon there that I was put in touch with by Rob Bono, and he was able to contribute a lot of patients as well. So the inclusion criteria was all patients who came to either center with a penetrating brain injury of any mechanism, and exclusion was pretty standard. Patients with unsalvageable injuries as determined by the attending neurosurgeon. So most commonly, very, very poor exam that would make escalating care futile and likely more risk than benefit. And then cases where family or legal next of kin decided to withdraw or not escalate care prior to performing the angiogram. So we explicitly defined what was going to count as a cerebrovascular injury to remove any doubt about what we're saying qualifies. So an intracranial pseudoaneurysm of any location or size, dural arteriovenous fistula, carotid cavernous fistula, a dural venous sinus occlusion or thrombosis, and then an occlusion of a major intracranial artery. There's not like a standard definition in the other studies that I discussed of what counts as a major or large vessel, but what I put together here made sense to me and all the authors, all of the faculty that were involved, and matches pretty closely with what's been published before. So the intracranial portion of the internal carotid, the M1, 2, or 3 segments of the middle cerebral, the A1, 2, 3, or A1, 2, or 3 segments of the anterior cerebral, the P1 or P2 segment of the posterior cerebral, the intracranial vertebral artery, which is V4, and the basilar artery, and then these 3 branches, the pica, aica, and SCA of the basilar artery. And that's for the definition of an occlusion of one of those, of a major intracranial artery. So we enrolled a total of 73 patients, 54 here from Harborview in 3 years, 19 from the University of Utah. Of those 73 patients, the mean age was 35, ranging from 9 to 72. The majority were men, a little more than 3/4. Whole range of Glasgow Coma Scale scores when presenting. I said we excluded anyone with hopeless exams, but the people with very low GCSs all had reactive pupils, and they actually also all had improvements in their exams. Their mechanism of injury, overwhelmingly, the most common mechanism was 86% were gunshot wounds to the head, which it fits with the largest previously published retrospective cohorts as well. There were 8 stab wounds, which was 11%, and then 1 nail gun and 1 crossbow bolt to the head. So our goal in this study, and I'm going to talk about this more later, was to obtain the angio as soon as reasonably possible after the patient came in, and we just find within 2 days as our goal. The median interval was our goal of 2, but there were some patients who didn't get their angiogram for up to nearly 2 weeks. All of the ones that were longer than about 4 or 5 days were for kind of unusual circumstances. Like, for example, at Utah, they had a patient that needed to be transferred from a small outlying center, and there was severe weather, so the patient couldn't get there for a while. Everyone who didn't have or there was an example of here at Harborview, a patient with ARDS and couldn't be transported for the angio. So everyone without circumstances like that were obtained. The range goes from 0 to 5 instead, and the median of 2. And then 70% got their angio within our goal window, 71%, less than 2 days, less than or equal 2 days. And then patients who had a lesion, a cerebrovascular injury that was confirmed by angio, and these numbers here are patients. These are the patients with a cerebrovascular injury that was seen on angio, and I'm not talking about whether it was seen on the CTA yet or not, was a total of 33 patients, of whom 19 had 1 and 14 had more than 1 injury. So 47 total injuries in 33 patients. which is an incidence in our cohort of 45%, which is on the high end of what's been previously reported in this series published in patients who were injured in war, 14 of whom had greater than one lesion. There were 13 pseudoaneurysms, 11 major arterial occlusions, 9 dural venous sinus occlusions, 8 dural AV fistula, and 6 carotid cavernous fistula. So I'm just going to show a few example cases because that's usually what's most interesting to everyone, including me. So this was a case of an injury that was missed by the CT angiogram and diagnosed on the catheter angiogram. So this patient had 2 lesions. I hope everyone can see my cursor. So this is a left internal carotid injection on the left side of the screen. This is the left internal carotid artery, ICA terminus, and this is the left ACA and MCA. And then if you look here, the majority of the left hemisphere is actually filling pretty robustly from the left side via the anterior communicating artery. And then the injury that was missed on the CAT scan on the CT angiogram was that there is a high flow direct carotid to cavernous sinus fistula on the right side. The reason and then this here is the left vertebral injection, basilar artery, posterior communicating artery on the right, and then this is the same fistula. You can kind of see these two things look the same. The reason I'm showing you left ICA and a basilar injection for a right carotid cavernous lesion is the right carotid artery was occluded. The CTA, as we learned from this study, is pretty good at identifying occlusions of large vessels. It doesn't miss very many of them. It's very bad at diagnosing dynamic things like dural arteriovenous fistula or carotid cavernous fistula. So the CTA told us that the internal carotid artery was occluded, and it was. There is an attempted ICA injection in this angio that doesn't go past the Petrus segment of the right ICA, but upon evaluating the other vessels, we can see that this patient had this fistula, which was transvenously embolized for cure. Here's another example of an injury that was missed by the CT angiogram and diagnosed on this angio. So this patient had bilateral small anterior cerebral artery pseudoaneurysms. You can see this one here. And then this is that same one on a 3D rotational angiogram reconstruction. Small, but the rupture risk of pseudoaneurysms is different than conventional intracranial aneurysms. So that size doesn't mean the same thing as it would if this was, a 2.5 millimeter unruptured saccular aneurysm. And then there's actually another one here. I don't have the 3D reconstruction of that one. In this distal ACA branch. The CT angio missed both of those. And then interestingly, this patient ended up getting another CT angiogram a few days later, and they still missed it, even with the benefit of hindsight from our angiogram done a few days before. One of these did enlarge over time and had to be treated. This patient is a sad story. Many of the residents know this patient, but a very interesting case in our study. So you can see this is a left internal carotid artery injection. This patient was shot in the left side of the head, and the entire left internal carotid artery from the distal cervical segment all the way up into the ICA terminus looks very irregular and unhealthy and dissected. And there are 2 pseudoaneurysms, one here at the origin of the left ophthalmic artery, and then one here at the origin of the left posterior communicating artery. And this actually, and there are other views that don't show each aneurysm as clearly, so I didn't put them up here, but there are other views where you can tell that there is actually a flap and a false lumen here leading to what looks like it's just floating here in space, but is in fact connected to the distal left ICA. This patient, he had a large degree of emboli from this lesion, had to be anticoagulated. The aneurysm, one or I believe both actually, but one or both of the aneurysms enlarged, and she ended up getting a flow diverting stent placed to manage these. The CT angiogram diagnosed the dissection and high-grade stenosis of the ICA, but did not diagnose the pseudoaneurysms. And then finally, we actually had quite a few. This finding surprised me. We actually had quite a few patients who acutely, in the first few days after injury, developed dural arteriovenous fistula, and I've always thought of that as a pathology that takes more time to develop. It's definitely known that patients get them after trauma, but this patient got their angio about 2 days after they were injured, and you can see here, this is a external carotid artery injection on the left side, that this is an early draining cortical vein. This is a parasagittal cortical vein draining to the superior sagittal sinus, being filled from an MMA branch, middle meningeal artery branch. And this is the beginning, this is a little whiff of contrast in the superior sagittal sinus. And then if your screen's like mine, this is probably blocked by the little thing that says who's on here. But if you move it, you can see that this is the distal frontal branch of the middle meningeal artery filling a cortical vein here. This is not a common type. This doesn't like super neatly fit into the way we think about spontaneous, dural AV fistulas, but this is a direct to cortical vein fistula. So I think of it as a Borden type 3 fistula that you would normally have to treat. This patient was lucky, and in follow-up, this resolved and, on its own, spontaneously thrombosed and did not have to be treated. And this, by the way, was missed by the CT angiogram. So getting a little bit more into our results. So it's 13 pseudoaneurysms, of which 9, nearly 70%, were missed by the CT angiogram. And then the CT angiograms misdiagnosed or incorrectly called 2 pseudoaneurysms that were in fact not real when we got the angiogram, or not present, I should say. And then 8 dural arteriovenous fistula of any grade, of which the CT angiogram missed all. 6 carotid cavernous fistula, which again the CT angiogram misses all, and then 9 dural venous sinus occlusions, of which the CT angiogram misses none, but misdiagnosed 3. In all cases, there was a large metal fragment that obscured the sinus, and in one case, the sinus was congenitally absent, and there was streak artifact affecting the CTA's ability to diagnose it. 11 major arterial occlusions, of which CT angiogram missed 3 and overcalled 1. So you can see CT angiogram misses a portion of nearly all the types of injury, but it's very bad at diagnosing fistula, either dural arteriovenous or carotid cavernous fistula, which is logical because those are dynamic, pathologies that are defined by an early draining vein, the presence of an early draining vein on angio, and the CTA is of course not able to discriminate temporally where the contrast goes. It has to be pretty large fistula for that to be evident most of the time on a CTA. So this equates to a prevalence of cerebrovascular injuries in our cohort of 45%. The sensitivity of CTA was only 36% and a 95% confidence interval, and that's calculated using what's called the Klopper-Pearson exact method of 20.4 to 54.9%. So at best, what that means is at best, in this cohort of people, if you account for 95% of all random chance, if you did this cohort over and over again, you would get a sensitivity of just better than 50-50. And then specificity was 85%. So CTA was substantially more specific, and it wasn't wrong about things it diagnosed nearly as often as it just missed things. This 95% confidence interval of 70 to 94%. And then this to me is a very interesting number. I kind of invented it for the purposes of this paper, but if you want to think about it like the number needed to treat, that's helpful. So I calculated the number of digital subtraction angios that you have to do in penetrating brain injury patients to find a single lesion that will change your management that is missed by the CTA. And in this cohort, that's 5.6, which isn't that many, especially since we're talking about injuries that have rupture risk, pseudoaneurysms in particular, but so do high-grade dural AV fistulas, And then, of course, carotid cavernous fistulas generally don't have rupture risk, but they can cause disability. So you only have to do between 5 and 6 angios to find something that you're probably going to treat, that you would have not known about, or you would have had to wait till the patient had a delayed hemorrhage or, delayed presentation of symptoms, ophthalmologic symptoms from carotid cavernous fistula and venous hypertension in the eye or whatever it was, to treat it. Or sorry, you would only need to do five to six of them to have the opportunity to treat it before it was a problem. Which is, to me, it's not that many for how severe the symptoms of not finding one, or sorry, the sequelae of not finding one of these can be. And then, of course, we care about treatment. As neurosurgeons, we want to know what we do about these things. This study wasn't designed to figure out how best to treat every type of penetrating cerebrovascular injury, and our center and the trend between what was done about them at our center and at the University of Utah is definitely different, and it was basically up to the judgment of whomever the attending neurosurgeon or neurointerventionalist taking care of the patient about what to do. But the actual number of lesions that underwent treatment, and if you think about it, this is really limiting it to the subset of pseudoaneurysms, fistula, really those two, carotid cavernous or dural AV fistula and pseudoaneurysms, because other than minimizing the risk of secondary injury or potentially medical treatment for anticoagulation of dural venous sinus thrombosis, not really an interventional option for occluded vessels that we do routinely in this in a trauma setting. It's obviously not the same as stroke. So 15 patients with 17 total injuries underwent treatment for a pseudoaneurysm, a CC fistula with or without a pseudoaneurysm, and then a dural AV fistula with drainage involving portical veins, which are the type of dural AV fistula that have a significant rupture risk. There were an additional 5 patients who underwent follow-up angiograms with the intent to treat, but were noted over time to improve and eventually spontaneously resolve, so they didn't require treatment. What treatment? I decided in our paper, we didn't get into exactly what was done too much, and I decided not to spend a lot of time on it here because we're not recommending one treatment strategy over another, and it's basically up to the judgment of the person treating it what's best. But everything was done in this case, from microsurgical obliteration of a very distal pseudoaneurysm to a variety of different endovascular treatments. Carotid cavernous fistula were treated transarterial and transvenous embolization. Dural AV fistulas were embolized with coils or liquid embolic, which is called onyx. There were a couple cases that our colleagues at Utah used liquid embolic for distal pseudoaneurysms to sacrifice the vessel that was filling the pseudoaneurysm. So the whole spectrum of open and endovascular treatment for cerebrovascular disease was used. That is something I'd like to look into more in the future about what's best, but that wasn't our question for this paper. So what we concluded was cerebrovascular injury is common after penetrating brain injury. CT alone is insufficient or very insensitive to accurately diagnose cerebrovascular injuries after penetrating brain injury, and that we recommend all patients routinely undergo digital subtraction angio regardless of findings on CT angio. And that conclusion and that recommendation is actually going to be voted on by the panel writing the next penetrating brain injury guidelines. The person I mentioned earlier, Randy Bell, actually emailed me yesterday to get our permission to vote on our manuscript prior to its being in print. And Dr. Levitt and I talked about it on Monday, and he agreed to that. So hopefully this conclusion will be communicated to all of us as a standard of care soon. And then just a couple of discussion points and future project ideas that I wanted to mention, and I think a few people might have comments or questions about that are related but different to this project. So what's the ideal time point to get these angios? So when we were developing this study, there were a few other centers that we were talking to about participating with us, and for a variety of different reasons, all but the University of Utah ended up falling through. But for example, Washington Hospital Center in Washington, D.C., which many of the people I know from military neurosurgery work there because it's near Walter Reed, and they've developed a relationship with them while they were still in the military. they've been doing angios on every penetrating brain injury they see for many, many years, but they do it at 7 days or, plus or minus after the patient comes in. So what they do is a CT angiogram when the patient shows up. If it shows something obvious, they obviously go proceed with an angio and treat it if it's indicated. But if it doesn't show something, which the majority don't, the majority of the CTAs don't show something, whether or not there's an injury there, like we just talked about, they wait until 7 days. And their logic is, one, the patients need to get a follow-up study at some point anyway. And two, if you wait a little bit, it may help to get the angio a little bit later to give the opportunity for anything that maybe have thrombosed in the acute injury setting to recanalize, or anything that's going to go away spontaneously anyway to go away. And then then you don't have to worry about it because the angio shows that it's gone. And that's very logical. The problem is that that is a very logical, physiological, plausible, but non-data based, just because everything in this area is pretty much there's not a ton of data guiding us on what to do. So we decided not to do that. We decided to do it early to try to catch anything that was present as soon as we could and react to it if we needed to. And that's what the University of Utah does. They were very happy with the 2-day time frame because that's roughly what they were doing before we involved them in this project. But it's not settled. It might be better to wait. And the more I think about it, that is in the case of a negative CT angiogram, there's probably not a huge downside to waiting 5 to 7 days because, I don't know. It just seems to me that there may not be. So maybe that's better. And the point is, there could very easily be a study comparing those two, should the angios be done early or late. The problem with that is that we would now have to redo this process of prospectively accumulating a cohort and then do one at 2 days and do one at 7. And I think it would take a much larger sample size to capture a statistically significant difference in that group. So it's a harder one to do. Another one that I actually did want to do with this project, but it proved just too heterogeneous to accomplish, was what predicts a false negative CTA in these patients. So there's some really obvious logical ones: retained metal fragments and streak artifact. Location of injury. In the case of a gunshot wound, does the bullet cross through the skull base, the face, or the orbit, which would put it, going through the head at the level of the circle of Willis? And also there's bone there which causes artifact that obscures everything. The size, caliber, velocity of projectile. The majority of civilian penetrating brain injury is with a handgun. That's very different than a blast fragment or a knife or a rifle bullet. Those all probably affect the likelihood of an injury in the first place and the likelihood of whether CTA is going to pick it up. And I think that is an interesting and actually by far the most common, the most complex to address of the reviewer comments that we got on our manuscript when we wrote our revision, was trying to address this, because everyone wants to know why the CTA seem to be so poor, and why, can we predict which cases it's going to be better or worse? And we can't do it with our data yet, but I think it'd be interesting to try. The best follow-up strategy. So, we talked about this a moment ago. Should you, right now, the recommendation is yes, get a follow-up study on patients who had initially negative study, and what should it be? Should it be an angio or a CTA? And when should it be done? 7 days, 6 weeks? No, we don't know. One that I've mentioned that I haven't spent as much time thinking about, but it's come up with some patients clinically lately, and then one of our residents, Eliza, is going to work on this project, is vasospasm after penetrating brain injury. How common is it? What causes it? Should we treat it like it's the same thing as spontaneous subarachnoid hemorrhage? We definitely have seen a couple cases of spasm in penetrating brain injury patients here, and at the University of Utah, Dr. Grandi actually treated 2 of the patients with IA verapamil for it. But that's, based on extrapolating data from the subarachnoid hemorrhage population, because we don't have any for this population. And then finally, a natural history study of penetrating cerebrovascular injuries that aren't treated. Which ones are likely to spontaneously resolve or worsen over time? Which ones should be treated right away versus followed? So that's a lot of ideas, but I wanted to throw it out there because it might inspire someone to make a comment. So at this point, take any questions or comments from.
Yeah, Mike, just one comment. That is really, it's a nice way to really focus on a question You asked a question, what's the best way to diagnose this? What's the incidence? What's the prevalence? And I think you really got down to answering it. Congratulations to you and the entire team of endovascular surgeons, which is really fantastic. So thanks for that presentation. Any questions from anybody?
Yeah, I just would chime in and say first, great job and great effort for a sustained and long-term, multi-center study. I think this is a good example of something that nobody wants to own these patients, right? So the vascular neurosurgeons are not particularly interested in traumatic brain injury in most places, and the TBI focused neurosurgeons don't do angiography in most places. And so I think that's part of the reason why this is a sort of understudied area. And I think this number needed to treat statistic, even if it's a single digit number needed to diagnose, is very unusual in surgical or diagnostic studies. And so even if the real number needed, even for over treating by a factor of 2, a number needed to treat of 10 that's a lot. I mean, that's low. And that means that this is really going to have a significant impact, I think, on practice. I mean, I think these data are pretty compelling that all of these patients should get a catheter angiogram at some point. And I think the questions you raise about timing and other things are relevant, and it may take a while to understand, but certainly this is going to have an impact. I guess my question overall for this cohort is, echoing some of the things that you had talked about in your discussion, which is, how many of these lesions would we have seen later? And the issue here is, well, what has been happening to these patients in the past historically, in terms of coming back with bad cavernous carotid fistulas, coming back with symptomatic dural arteriovenous fistulas, coming back with pseudoaneurysm ruptures. If you don't look, you're not going to find, unless there's a problem. And the question is, how much of a problem was this in the past? I don't know that we can answer that question with this cohort, but I wonder if you looked at the literature previously about, I know you reviewed it a little bit, but just the number of patients, the incidence of these treatable lesions or dangerous lesions.
Yeah, so I tried very hard to find, because when you and I talked about this number needed to treat or number needed to find idea before we submitted the manuscript, and I tried to find a way to put it in context of compare it to how many using historical control, how many would have presented with severe symptoms later. And their problem is I can't find, you can find many case reports and case series of people who, present with severe ophthalmologic impairment or rupture in a delayed fashion, but I don't know what their denominator was. And the answer is I don't think anyone knows. We do know, of course, we see a reasonable number of patients every year here that you or Dr. Kim or who, one of us treats who has a history of trauma that could have easily been a cause of a fistula that they have. But for pseudoaneurysm, I think that it's a lot more binary. I think many of them probably thrombose. My gut instinct is that they probably go, most of them go away.
And I think the dural AV fistula also, it's probably not an actionable. Sorry, we got very vehement opinions. Not an actionable lesion most of the time.
Yeah, especially the dural AV fistula is our own experience with the 9 that we had. Majority went away. But the CC fistula seemed,
CC fistulas for sure. But I guess that's why I think even, if you excluded those 9 dural AV fistulas that probably would spontaneously thrombose, maybe all of them or maybe most of them, you're still going to end up with a number needed to treat of 10, which is also a very small and therefore high impact number needed to treat. So my last question, I don't want to monopolize the discussion, but my last question would be, how should we here at Harborview codify this into how we practice it, or should we wait? Is there something we should be doing on the trauma side, on the vascular side? What if you could write the ideal sort of protocol for a patient like this? I'd ask you to think about what that would look like so that we can turn that into something actionable, because I think this is, at least it's the worst data except for all the other data, right? It's actually pretty good data. And so should we operationalize this?
Yeah, thank you, Mike. I like that. I mean, nothing better than changing the way you practice to get a better
Well, I
outcome.
mean, even recently, Dr. Bono's work on blunt cerebrovascular injury absolutely changed our practice. And so,
Yeah.
we're not set in amber here. And I think this is the type of study that really ought to change our practice in terms of looking for these lesions. So, Mike, what would be your ideal? Is everybody get it between day 1 and 7? Are we going to try and do something where if the CTA is initially negative, we do it within 7 days? What would you like to see here?
Yeah, so that's I'm glad you brought that up. I actually have been thinking about changing our protocol to be 2 days, within 2 days for everyone. I think in a negative CTA and a CTA that is not terrible quality, meaning that you can get some valuable information from it, and that's of course subjective and or judgment based. But I think we should probably reconsider our early time point and maybe do it more along the lines of 7, because it will serve multiple purposes. It will get the angio we need, and it will serve as a follow-up study. Because right now these patients are all getting 3 studies. We're doing a CTA, an angio, and then another CTA in the ones that are negative. At 7 days. That's what we're doing. And all the people, all the residents and faculty that work with the trauma service that's been our protocol since we started doing this study. I think that if we have an initially reassuring CTA and we can delay the angio, and then it serves as a good time point for follow-up as well. 1, 2, I think that if the angio shows a fistula, whether it's carotid cavernous or dural AV fistula, I think we should come up with, and I'll probably ask you and Dr. Kim's opinion on the ideal timing of this, but I think we should plan on a follow-up angio for all of them so that 1, we don't miss any, and 2, we don't treat the majority of what are likely to go away. And then for pseudoaneurysms, I think a size or morphology criteria of whether to treat up front or not. It's really hard, right? Like I showed those distal ACA pseudoaneurysms. It's not a trivial endovascular thing to treat them, whereas if it's like a supraclinoid ICA pseudoaneurysm, it's a lot, more proximal. So I guess I need to think more about what to recommend for pseudoaneurysm. I definitely think we need to take them very seriously. I'll just give one anecdote. When I was a junior resident, there was a girl, a teenager, whose boyfriend accidentally shot her. And she made a pretty, Dr. Bono was the chief, and he and I operated on her, and she made a pretty spectacular recovery, actually. And then she had headaches for a few days, and then all of a sudden she died from a ruptured pseudoaneurysm of her left M1 distal ICA. And going back over the CTAs, the first CTA missed it entirely. The second CTA, the fellow read missed it entirely, and the neuroradiology attending overread just said subtle irregularity of the terminal ICA attention on follow-up. So which no one, we as a team admittedly missed that, but that's also like a very subtle thing to raise an alarm over. So I think that I do think we need to take them very seriously, but I think that jumping to the conclusion of treat every pseudoaneurysm because it's there is probably over treatment. And there are places that do that, by the way, that I've talked to, that they just do a liquid embolic injection into whatever distal branch every time they see one. I'm not saying we need to do that. I don't know if that was kind of a rambling answer. I'm not sure if that gets to what you were.
No, I think it just goes to the heart of the difference between a paper that's in a clean, straightforward language and then operationalizing the findings to something that you can actually point to when a new patient comes in. There's a gap there that is important to think about and address. And I think we as a group of TBI, general neurosurgeons, TBI and vascular neurosurgeons need to kind of decide. I like the idea of waiting a little bit because I don't like the idea of over treating, but I think there are certain lesions that clearly need treatment. So, I think we're going to end up with an idea here of a protocol that is based on, patients come into penetrating brain injury that look like this. Most of the time we're going to get an angiogram in 7 days or whatever. But you and I and Dr. Bono and others can think about this, and I think we should really try and codify this. This should be a Harborview standard.
Okay. Good, good.
I would agree with that, and I just really want to applaud Dr. Meyer for an outstanding study that I think really will move the needle in terms of practice here, but also other places that aren't as haven't been as aggressive with angiograms. It's really an impressive amount of work, and he's done a great job. So cheers to him for that.
Thank you very much, Rob. All right.
I would just make the final comment here that all of this is contingent on quality diagnostic angiography. There are centers that shy away from this procedure because they're afraid of complications. It wasn't too long ago that the vast majority of diagnostic angiograms done at a center were done by diagnostic neuroradiologists, not interventionalists or neurosurgeons. And so I think that this study can only be done if the quality of the angiography is at a very high level with low complications and low stroke risks and so on, hopefully low access site complications. I think that the death of catheter angiogram has been grossly overstated. Everyone keeps thinking it's going to go away, and the reality is that it provides, as Mike's study shows, an incredible amount of additional information that no non-invasive imaging study can give. So but at the same time, this can't be codified across the nation for that same reason, is that the quality of that endovascular and diagnostic work is variable. So, it just depends. There are major centers in the country who actually don't have that same complication risk or rate or whatever. So just something to keep in mind as you guys think about on a national level about how to bring this in. And the vast majority of studies I suspect were done by Melanie Walker, who is a fantastic diagnostic, angiographer. But again, I think she's way above the average in terms of experience and so forth. So something to keep in mind.
Yeah, well,
I think that's
thank you very much. Congratulations to Mike, Lewis, Melanie, and Raj, and soon to be Stephanie's just started again. So you're right. You guys are amazing. And yes, Melanie, you rock, because you end up doing most of these because you say yes anytime something has to be done 10 to 2 in the morning, your block time. So thank you for the great cerebral angiographers that are in this department. I think your point is very well taken, and we don't say it enough, Lewis. Thank you. Mike, did you want to say something before we sign off? I apologize. I interrupted bragging about.
No, I was just going to follow up with what Lewis said and just say, like, there are two ways to change practice. One is to wait for the expertise and ability to catch up with the guidelines, and the other is to put out the guidelines and throw the gauntlet down. And I think Lewis, you're totally right. A lot of places aren't going to want to do this, but maybe if it's guidelines, then they're going to be forced. They're going to be forced to adopt a more aggressive stance, and they're going to be forced to provide higher quality care. I mean, just because it's hard doesn't mean we don't do it. So I think you're absolutely right that a lot of centers are not going to have this ability, and maybe that's going to change practice over time, but we can't control that. I think we have to really, really push the issue here that it's hard, but it's important. So I think your comment is valuable, and hopefully these guidelines help to push the practice in the right direction.
Mike, thank you for really riling up the crowd. Good academically, I'm not talking in anything but a positive way. Really great work, great kudos to all our endovascular and cerebral angiographers. I really can't say enough about the willingness to do anything indicated any time of the day. It's mirrors the rest of the department and leads the rest of the department. So thank you very much, everybody. Have a nice day.